Here is our roadmap for the journey today. We'll start with the science of grafts, then move on to mastering surgical flaps, tackle managing and preventing bed sores, and finish up with advanced wound dressings. Let's get right into it.
Section 1. The Science of Grafts.
Before we do anything else, we have to clearly distinguish between the two most vital tools in a reconstructive surgeon's arsenal, the graft and the flap. And really, it is entirely about blood. A graft is a piece of tissue that is completely severed from its native blood supply. When you place it on a wound, it's 100% dependent on the blood supply of that new recipient bed to survive. A flap, on the other hand, is a piece of tissue that gets moved to a new location, but it maintains its own dedicated blood supply. It literally brings its own life support with it.
Now let's look at the constant clinical trade-offs surgeons face between split-thickness and full-thickness grafts. A split-thickness skin graft, or STSG, is thin. We harvest it using a specialized tool called a Humby knife, usually from a large donor site like the thigh. Because it's so thin, it needs fewer nutrients, which gives it a fantastic survival rate. But the trade-off? High secondary contracture. That means it shrinks a lot after it heals on the wound, and it kind of tends to turn dark over time. Now contrast that with a full-thickness skin graft, or FTSG. This includes the entire dermis. You harvest it with a standard scalpel from places like behind the ear. It shrinks immediately upon harvesting, which we call high primary contracture, but it gives you vastly superior cosmetic color matching and resists trauma so much better.
So how does a severed piece of skin actually survive in a totally new home? It's kind of a miraculous three-phase mechanism. Phase 1 is imbibition, which happens in the first 24 to 48 hours. The graft basically acts like a sponge. It survives purely by absorbing a plasma-like fluid and nutrients directly from the recipient bed. Phase 2 is inescalation, happening right around days 2 to 4. This is when tiny capillary buds from the recipient bed start physically growing up into the graft. And finally, Phase 3 is neovascularization, starting after day 4. This is where the blood vessels of the graft and the recipient bed actually connect and form true anastomoses, fully restoring that blood flow.
Of course, it doesn't always go to plan, right? It's crucial to know the enemies of graft survival. The absolute most common reason a beautiful graft fails is a hematoma or seroma. That's a collection of blood or fluid beneath the tissue that physically lifts the graft up so it literally can't absorb nutrients. Infection is another massive killer, particularly beta-hemolytic strep or staph, which can just eat the graft. Any movement or shearing forces will disrupt those super fragile new blood vessels during inosculation. And lastly, a poor recipient bed. You absolutely cannot place a graft directly on bare bone. If the bone lacks its periosteum, that vital outer vascular layer, the graft is practically guaranteed to die.
Before we leave grafts, I want to point out a vital detail about skin banking. Burn units often have skin banks that store split-thickness grafts for later use. This skin is kept at 4 degrees Celsius and can survive for about 2 to 3 weeks. You can store it in media like CO2 snow, glycerol, or liquid nitrogen. But here's the crucial point, and this is a trap for a lot of people. Formalin is strictly forbidden. Formalin is a chemical fixative. If you use it, it will kill that living tissue instantly.
Section 2. Mastering surgical flaps.
Okay, when we talk about axial flaps, which are flaps rotated on a specifically named blood vessel, we use the Mathis and Nahai classification. This helps us instantly visualize how different muscles are vascularized by their pedicles. A type 1 flap has just one dominant pedicle feeding it. Type 2 has one dominant and one minor. Type 3 is incredibly robust. It has 2 dominant pedicles. Type 4 relies on a network of multiple minor pedicles. And Type 5, like the latissimus dorsi or pectoralis major, features one dominant pedicle plus multiple smaller ones. Understanding this map is exactly how a surgeon knows what tissue they can safely move.
Let's look at head and neck reconstruction, where 2 major flaps really rule the roost. Contrast the deltopectoral flap with the PMMC, or pectoralis major myocutaneous flap. With the DP flap, the blood supply comes from the medial side. Those are the internal mammary perforators, so the flap is lifted laterally and rotated medially up to the neck. The PMMC flap, however, is based on the lateral side, relying on the pectoral branch of the thoracoacromial artery, so you lift it medially and rotate it laterally. Keep in mind, the PMMC is truly the ultimate workhorse for head and neck surgeons because of its sheer size and reliability.
Now, let's see how this builds into breast reconstruction. The latissimus dorsi, or LD flap, is a great option. It takes skin and muscle from the back and tunnels it forward. Another option is the tram flap, which brings tissue up from the abdomen, but here's the catch. It takes the rectus abdominis muscle with it. That creates a really severe risk of abdominal wall weakness and incisional hernias. Because of that, the clinical superiority of the DIEP free flap is absolutely clear. The DIEP flap takes the exact same abdominal skin and fat, but the surgeon painstakingly dissects out the blood vessels to completely spare the abdominal muscle. It is clinically the best option. No hernias, and the patient gets the added bonus of a tummy tuck.
So what happens if a massive oral tumor requires removing the actual jawbone? This is where we see the fascinating clinical application of the free fibula flap. The fibula bone is removed from the leg, along with its perineal blood vessels, detached entirely from the body, moved to the face, and then reconnected to the neck vessels using microscopic sutures that are literally thinner than a human hair. This is the absolute gold standard for completely rebuilding a missing lower mandible and correcting severe conditions where the floor of the mouth collapses. Because flaps totally rely on their intricate blood supply, they will fail if those vessels clot. You absolutely must know what to look for on ward rounds. Let's contrast the distinct physical signs of arterial versus venous flap failure. If the artery is blocked, fresh blood can't get in. The flap will be pale, cold to the touch, and have a delayed capillary refill. But if the vein is blocked, blood gets in but can't get out. The flap will feel warm, but it's going to look aggressively congested, swollen and dusky or purplish with a very rapid capillary refill. Spotting this early is the only way you can rush the patient back to the OR and save that tissue.
Section 3. Managing and preventing bed sores.
30. This number is incredibly important. 30 millimeters of mercury. That is the exact pressure threshold that triggers tissue ischemia and death if it's sustained continuously. If a bedridden patient lies in one position for too long, the pressure against the mattress exceeds 30 millimeters of mercury, completely cutting off capillary blood flow. The tissue literally suffocates and dies, and the most common site for this catastrophic breakdown? The ischium, that lower part of the pelvic bone.
When you look at the 4 escalating grades of bed sores, notice how they strictly mirror the classification of thermal burns. Grade 1 is your warning sign: redness or non-blanchable erythema. The skin is intact, but it's angry. Grade 2 involves partial thickness skin loss of the epidermis and dermis. Grade 3 is a deep crater extending down into the subcutaneous fat. And Grade 4 is truly severe: complete tissue loss exposing raw muscle and deep bone. At Grade 4, you're essentially looking at needing another massive surgical flap just to cover the defect.
Because treating advanced bed sores is so incredibly difficult, prevention is absolutely everything. These strict preventative measures prove that consistent nursing care and proper nutrition are just as vital to patient survival as the surgery itself. Bedridden patients must be turned every 2 hours. Wheelchair-bound patients must literally be lifted off their seat for 10 seconds every 10 minutes to offload that pressure. You have to maintain their nutritional status, ensuring serum albumin stays above 2 grams per deciliter. And we utilize specialized air or water mattresses that constantly shift pressure points so no single area gets sustained compression.
Checking for these entirely preventable ulcers has to become an ingrained habit for every single medical professional walking the wards. Checking a patient's back during rounds shouldn't be an afterthought. It should be an absolute reflex. If you haven't looked at the patient's skin, you simply haven't completed your medical examination.
Section 4. Advanced wound dressings.
-125. This is the specific pressure setting in millimeters of mercury that we use for a vacuum-assisted closure, or vac dressing. By applying an occlusive seal and hooking the wound up to a machine pulling continuous negative pressure, you actually physically accelerate wound healing. It aggressively sucks out infectious exudate and muck, while at the same time pulling inflammatory cytokines into the bed and dramatically boosting local vascularity. It is a total game changer for chronic wounds, though you do have to watch out for bleeding, which is its most common complication.
For standard dressings, you need to know exactly when to use what. If you have a highly draining, weeping wound, you want alginate or foam dressings, which are highly absorptive. But if the wound is dry and needs a moist environment to heal, you switch to hydrocolloids or hydrogels. These are non-absorptive and actively rehydrate the tissue. Now, collagen dressings are excellent for burns, but they carry a massive caveat. You absolutely must avoid them in infected wounds. Why? Because bacteria release collagenase enzymes that will literally eat your dressing instead of letting it heal the patient.
And that brings us to the end of our masterclass. We've seen how modern plastic surgery can detach bones and reconnect blood vessels smaller than 0.5 millimeter in super microsurgery. But I want to leave you with this final thought to ponder. Even amidst these incredible microscopic surgical techniques, does basic human diligence,
like the simple act of turning a patient every 2 hours to prevent a bedsore, remain our absolute most powerful medical tool? It really is the balance of high science and dedicated human care that makes true healing possible. Thank you so much for joining me in this explainer, and I'll catch you in the next one.